Yeah, got it. Okay, so good morning, everybody. I can't see all of you today. So whoever you can see me, so good morning. Today, we're going to talk about I titled syncope because it covers mainly syncope, but um, the other things which I want to cover here is T-lock or transient loss of consciousness, which most of you would have encountered in your clinical activity. Just we going to see how we're going to uh, assess, evaluate, and manage this type of patients presenting to the ED. And I am giving the option of interrupting me while presenting so that we can clarify things as we go along in case if it's something is not clear to you guys. I'm not sure I can see everybody up around here. Fine. It's quite slightly not very interactive, the actual physical presence of few people here. But let's make a start and see how we go along. Fine. So the objectives for the next 40 minutes or so is to able to define syncope and identify those conditions presenting with syncope, able to build history, to detect orthostatic hypotension, arrive at differential diagnosis and initiate appropriate investigations. It's very important, and that follows what we get from the history and what we think about it in our evaluation. So that guides our investigations and appropriate early management or reassurance or follow-up, and to apply some guidelines in the evaluation of the syncope. And last but not least, these carry a risk to the individual presenting at syncope. So just need to advise them to see what they can do with their daily life in terms of driving and arranging appropriate follow-up. Fine. Syncope. So how do you define syncope? It is okay, somebody joining us. Okay. So it's a rapid onset of symptoms caused by brief loss of consciousness, which involves loss of muscle tone and posture resulting in the fall. But it has spontaneous and rapid complete recovery. So that is very important. The recovery is spontaneous, rapid, and complete, and that is underpins the definition. Otherwise, you can have other things which are included in the diagnosis, and it caused by the transient global cerebral hypoperfusion. That is the bottom line in this diagnosis. This is a underlying pathology which contributes to this rapid onset symptoms, brief LOC, and which is leading on to the loss of muscle tone, leading on to the fall, but it is followed by rapid and complete full recovery. So what is it different? How does it differ from T-lock or transient loss of consciousness? I mean, it's syncope is an entity within the T-lock, but it includes other things like non-epileptic seizures or epileptic seizures and non-psychogenic causes. Those are the other two entities under the umbrella of T-lock. Transient loss of consciousness, again, I mean, if you see, it is, as the name suggests, it's got loss of consciousness is involved, and there's loss of motor control, and there's loss of responsiveness, and there's period of amnesia and short duration. How does it differ from syncope? It's not much difference, except that there are certain syncope. It's a very, very, very narrow defined group of things which are included in that category, whereas in T-lock, which are not clear cut in our evaluation, like such, for instance, could be epilepsy, could it be a psychogenic? We don't know. So those things we term it loosely under the umbrella of T-lock. And main thing is two types of traumatic and non-traumatic. Traumatic is when we see in head injuries and stuff associated with head injury. When there's loss of consciousness, we don't call it transient loss of consciousness. We call it like a head injury and manage as a head injury and stuff. The other things are, which I'm talking about are the non-traumatic T-log, which include syncope, epilepsy, psychogenic seizures and stuff. Okay, so hope that made it clear, and that we can proceed further from that. Otherwise, if it is not clear, then I'm sure it should be self-sufficient, self-explanatory. This one. Excellent. So, in other words, what I was trying to say earlier on, I'm just putting this simple slide. So transient loss of consciousness includes syncope, which can be the neural mediated cardiac arrhythmia, structural orthostatic hypotension. It can be a feature of acute illness, sudden either cardiovascular problem, or it can be a massive stroke, or if there's any metabolic reasons or any seizure activity, anything which can be there as well. Yeah, they are all loosely under the umbrella of transient loss of consciousness, whereas we're going to see more only due to the syncopal episodes. Another one, the category of a syncope, we're going to deal more here. Okay. So, how do you classify syncope? Can be due to, as I said, it's neurally mediated, due to orthostatic hypotension or cardiac causes, which can be the structural or can be due to arrhythmia related. Yeah. Excuse me. This is a non-COVID cough, by the way. So, yeah. So, neurally mediated orthostatic hypotension, arrhythmias, or due to structural causes, structural cardiac causes. Again, non-syncopal can be because of any of these reasons, psychogenic seizures, or hypoglycemia, so that not anything else. So, what are the types of the syncope you see in the reflex neurally mediated syncope? It could be vasovagal or situational, or carotid sinus. A situational can be any of the various situations you can see: cough, maturation, swallow, defecation, emotional. Maturation is most commonly seen in younger patients, younger adults, yeah, predominantly males. Vasovagal is when you the most common form of reflex-mediated syncope, and predominantly seen about up to 1/3 of the population can have vasovagal episode in their lifetime. And carotid sinus syncope seen most commonly in the older age groups. What is the pathophysiology behind it? And it is, I'd say, if you see this slide clearly, the main common things is the common pathway is the global cerebral hypoperfusion. And how does it, how is the, what leads on to this final pathways? It can be because of the cardiac reasons, or could be reflex, neurally mediated, or due to syncope, secondary to orthostatic hypotension. So it can be either because of a low peripheral resistance or low cardiac output, or it can be because of both, and that leads on to that. So if you see this one, in the vasovagal type, it can be because of the any stimuli. Okay, most often it's due to external stimulus. Fear, pain, situations with any instrumentation or unfamiliar surroundings, a prolonged standing, all any amount of anything which triggers the abnormal autonomic reflex response, causing increased vagal tone, and that leads on to reduced heart rate, or it can sometimes inhibit the sympathetic tone, leading on to loss of arterial, loss of peripheral resistance, and that leads to the bradycardia causing the bradycardia as well as hypotension. So immediately, sometimes we after a syncopal episode, if you measure blood pressure and check the heart rate, they can be bradycardic as well as hypotensive. That's only for a short period. And as they are as they are lying supine, then you can find the blood pressure return to near normal, and the uh, heart rate return to near normal as well. So if you interrogate the paramedics notes, and you can find these bradycardic hypotensive episodes and blood pressure things as they are documented that in their in their assessments and monitoring stuff, the paramedics. So that will tell you the what was the and they can also be a sometimes a brief fitting episodes, yeah, fitting quote unquote fitting episodes, yeah, where they can have some jerking episodes noted there, and it's all down due to because the bradycardia or hypotension causes reduced cerebral hypoperfusion. That means there is reduced oxygen going to the substrate, delivered to the brain, and that can contribute to the fitting episodes seen. And most often they are seen after the patient is supposed to fallen down after the episode has started, and they are very brief, and the recovery is quick and rapid and complete. And that may be differentiated from other things. So the fitting episodes we see because of this cerebral hypoperfusion, which can be because of the bradycardia and or hypotension. Yeah. This is the underlying mechanism behind this. And we touched upon earlier the cardiac causes can be because of arrhythmia, because of structural, that leads on to mainly the low output state. Whereas the arrhythmia can be because it can be faster or can be slower. And similarly, the reflex mediated, it can be either because of most sometimes it's mixed, sometimes it can be only due to hypotensive vasodepressor mechanism where the reduction the sympathetic nerve system causing to peripheral pulling and leading on to reduced return and reduced output. Whereas it can be also due to a cardiac inhibitory where there's increased vagal tone causing bradycardia and the low blood pressure, low cerebral hypoperfusion. And similarly, that's the same story in orthostatic hypotension, where can due to primary, secondary, or due to drugs and stuff. But final common thing is, again, that is low peripheral resistance causing peripheral pulling, causing return of reduced venous return, causing reduced blood pressure, causing the syncope. Okay. Fine. Carotid sinus is one of the other forms of the neurally mediated. It's basically the same kind of response, but because it's seen in the older people where there is external compression to the neck, which can, when they turn the neck to side or when they're shaming and stuff, and that causes some external pressure that can lead to abnormal response from the carotid body, which is like a pressure sensitive organ located in the carotid at the bifurcation, and it involves two responses. It could be the cardiometry causing bradycardia and asystole for more than 3 seconds, or it can cause vasodepressor response, abdominal fall in blood pressure more than 50 millimeters systolic, without any change in heart rate. And this can be reproduced if we, along with the reproduction of the abdominal vagal response, plus the vasodepressor response, plus the reproduction, along with the reproduction of symptoms, then we can diagnose the abnormal carotid sinus hypersensitivity or carotid sinus syncope. Often, as I said, the age group, the demographics we see is predominantly older men, and history can be sometimes classical. And I'm fine, sudden turn in the head can be confused with the what is it. What is the other possible differential you can think about? It can be BPP because when you turn the head, I'm feeling dizzy, lightheaded, vomiting, that kind of thing. Again, the PPV, which is potentially curable or curable if you do the Epley's maneuver, but diagnosed with by the um, Dick Halpeck maneuver. When you see turn the head to the side, and then you obviously you need to exclude a um, any potential cervical spine problem before you undertake this Dick Halpeck or replacement to diagnose this kind of stuff. So that potential differential is the BPPV when you think about carotid sinus hypersensitivity or syncope. Yeah. So it is. I just want to see some faces here. That's why I'm just pausing and looking at the videos to see overall here. Feels a bit unnerving to talk to myself. Excellent. Next one. The next type is the orthostatic hypotension. Just 1 second. I'm trying to rearrange the. Can we do primary or secondary? Primary when there is primary autonomic failure due to Parkinson's or any Lewy body dementia or any there is no and structural causes found. Secondary when there is diabetes or renal failure or any spinal cord injuries, when there is thoracic upper spinal cord injury. Volume depletion can be due to hemorrhage, internal or external. Yeah, consider hemorrhage sometimes when you diagnose, sometimes not very often. Sometimes you can find that out a leaking AAA like that, which is happened. Patient presented with some dizzy episodes. At least a couple of times I diagnosed in the ED, just classicals. Young, not young, a 65-year-old man, fit man, apart from had a recent stent put in for enstomy. Suddenly felt lightheaded while he was doing a hoovering in his house, and then he couldn't lift his head up at all, and just felt like that as soon as it sits up, or signs of very lightheaded, and it's happened suddenly. It was getting ready to go out, and then happened suddenly. It was otherwise completely fine, no reason, viral illness, nothing like that. And blood pressure was around 100 systolic. For 64-year-old man, 100 systolic is hypotensive. There is no evidence of any bleeding, nothing, no pain, even no back pain, no chest pain, nothing at all. For some reason, because it's 65 and it is hypotensive, I just did a fast kind of massive blood in his belly. And that turned out to be ruptured, one of the ruptured splenic artery or some vessel was ruptured, not AAA rupture. And another is I have an elderly man who's 70-year-old coming some non-specific symptoms again, lightheadedness on standing up, found to have significant postural. In fact, he collapsed when he was trying to stand up when you're doing the postural blood pressure. And then again, one of the registrars in the scan found to have again massive blood, which is second to AAA. So concealed hemorrhage can very careful when you reproduce the symptoms before you do instruct the nurses to do the blood pressure checkup to diagnose orthostatic hypotension. If they have symptoms, if they have history suggesting that, oh, I will stand up, I feel like or fell down when I stood up. It's important that we pin down the history and then see whether it could be some internal concealed hemorrhage, or there's explicitly if there's any volume loss to DMV, you can anticipate that. And most often there is no evidence of any bleeding, or sometimes the history is muddled because of the patient's other comorbidities. They have some cognitive impairment and they can't make out history, or there is nobody who can witness it, or those kind of stuff. So, but most of the time in medications are contributory factor. If not, they are the only reason behind it. Because there's a diuretics or antidepressants, all this kind of stuff. Yeah. So how you diagnose it? Say orthostolic of more than 20 or diastolic more than 10, or if systolic drops below 90, then you diagnose it along with the reproduction symptoms. And symptoms can occur within 3 minutes of, of standing. And prior to checking the blood pressure, patients should be lying for at least 5 minutes before you check the blood pressure. So it should be checked at 1 minute as well as at 5 and after 3 minutes. And sometimes that is, and I'll come back a little later to the types of orthostatic hypotension. And you have to exclude, when you diagnose the orthostatic hypotension, you need to check for the causes. Yeah, that's very important. It's not simply enough that you say, oh, the patient's got orthostatic hypotension and blood pressure is so low and they need to come in. Yes, you're finding out the reason behind why they fall, but it's also important that you have to find out the reason behind why they got orthostatic hypotension before putting it down to medications alone. You have to make sure you're ruling out the serious causes. You know, it's any concealed hemorrhage, or is there any volume loss, or they got any AKI, all the other things, or can be, unfortunately, undiagnosed Addison's present, things like that. Patients who are on long-term steroids, like patients who are rheumatoid arthritis on long-term steroids, have they been under for some time, this underlying steroid deficiency. So you need to think about it. So before you put down to this, all down to orthostatic hypotension, and not trying to diagnose the primary orthostatic hypotension, primary autonomic failure. You're not diagnosing that. So it's important that you find out the reason behind why there is the orthostatic hypotension. Medications can be contributory factor. Is there any other illnesses which also present along with that? That is very important. Yeah, that's what I will ask you. If you come to me with this, blood pressure is low and so, and you diagnose, well done, but what is the reason behind it? So just have a little think about it before you dispose the patient off. Yeah, so medicines, medications, hypervolemia, dysfunction, autonomic dysfunction, endocrine, they all can go down to orthostatic. Orthostatic hypotension, the classify again into initial and classical and delayed. Initial is when the symptoms happen within, when they stand up quickly, and it normalizes when he's standing. Yeah. The classical is when there's a fall blood pressure on a shin in the upright position, and it continues to be abnormal. And you notice the fall blood pressure from about 20 systolic, and 20 millimeters in systolic, or 10 millimeters diastolic, or a total fall of systolic less than 90. In delayed or orthostatic hypotension is when symptoms don't appear for the initial 3 minutes and start slightly after the 3 minutes of assuming that once you become the upright position, the symptoms start to happen after 3 minutes. And you still diagnose them in the orthostatic hypotension. Yeah. So that is some clarity behind it. They kind of the European Society have divided this as initial, classical, and delayed. Initial is when they get up and stand and walk, and then they fall down 3 to 4 meters away. And then that's initial. And then classical is when they get up and then stand up 3 minutes, and the symptoms continue to be abnormal. Whereas for delay, where you completely fine for 3 minutes, and then symptoms start after 3 minutes. So I think it's better to check the blood pressure maybe at 5 minutes intervals, along to 1 minute, 3 minute, 5 minute, maybe. Maybe we can change it. Coming to cardiac syncope, is caused because of the arrhythmia, maybe bradycardic tachyarrhythmia or structure. Bradyarrhythmia can be a sinus, because it can be turned due to sinus of dysfunction, heart blocks, second to third heart blocks, or if they have a pacemaker, there's a the implanted device is a dysfunction due to the implanted device. Yeah, it can be a abdominal firing or pacemaker dysfunction here. Tachyarrhythmia can be VT, non-system VT, or SVT, but also the points. Atrial flutter or atrial fibrillation flutter, which leading on to compromising blood pressure. Structural causes can be the Hockham, valvular, MI, tamponade, vascular reasons. Again, great vessel disease could be massive dissection or pulmonary hypertension. So, any structural reasons involving the great vessels uh, or the heart itself. And what are the ECG abnormalities which can contribute to pretty much everything, to be honest? The syndrome is block, bifascicular block, QRS more than 0.12, and asymptomatic sinus brady, consistent BT, peak ZX, QRS, long or short QT, and regarded pattern syndrome, QAs, suggesting of dysymptomy. So pretty much any abnormality can pretty much contribute to, if you in the absence of these any abnormal ECGs, then you can suggest, I can say possibly it could be a resurvival, especially in your thinking about in age groups of 50 and 60 and stuff. But you have to rule out structural problems. That is very important. Okay, so ECGs. I just wanted to say somebody can volunteer for what do you see on the ECG. I've been talking for nearly 10 minutes time. Yeah, 20 minutes.
Is it sinus tachycardia?
Yeah, sinus. Is it or sinus, or is it? It is.
Sinus tachycardia with marginal, like benign early repolarization type
Yeah,
pattern.
I get it. I just want to pull a legs, Rangani. Sorry, it is sinus tachy, nothing else. Yeah, just sinus tachy. That's it. Yeah. Next one.
First degree
heart block. First degree heart block.
Yeah. Yeah.
The PR is prolonged.
Yeah. Yeah. Next time, somebody else, apart from Rangani and someone who's the male voice, I didn't see. Somebody else. Go on, Ankit. You're looking very serious.
Right bundle. Right bundle.
Okay, go on, Rashid.
Right bundle branch block.
Bifascicular block.
Absolutely, yeah. Bifascicular block.
Okay.
Right bundle with the left hand giving block. Yeah.
Yeah.
So bifascicular. Okay. Fine.
Complete heart block.
Yes. Yeah.
There is also right bundle branch pattern in this ECG.
Yeah. Then you can say left anti-hemi block as well.
Trifascicular block.
Trifascicular block.
Yeah, so it's two trifascicular blocks. So it's you can say complete heart block because the PR pattern is is varying. Can you see the relationship of PR is here PQRS, but there is maybe PQRS, but QRS. The relationship is varied, so it can be complete heart block. But yes, so yeah, it's trifascicular block with a complete heart right bundle branch with a left anti-hemi block. And you can say it's prolonged PR interval, but that's a misnomer apparently. What we used to think about is trifascicular block. I learned yesterday. The bifascicular block prolonged PR is not trifascicular block. Trifascicular block apparently is right bundle branch block, left anti-hemi block. That's a complete heart block. And the previous, yeah, you see what is this one?
It's Movitz type 2, I think.
Yeah, who said that?
I.
Saurabh, is it?
Yes.
Ah, okay, sorry. Yeah, good, Saurabh. I couldn't see you.
Mm.
Yeah, so Movitz type 2, yeah, 2:1 block. Yeah. And Movitz type 2. So all these ECG, why I'm showing all these ECG patterns. So these patterns are all significant. So for instance, if you see a patient who has these ECG abnormalities, then you have to think about monitoring them and admitting them. So they don't know if they don't have these kind of abnormalities in ECG, or is it something which is seen incidentally, and or is it contributing to their symptoms? We don't know. So any of these abnormalities in them, which leads to further investigation and possibly monitoring and admission stuff. Okay, Brugada pattern, yeah. So I put it on the ECG. So this coding pattern, coding type of RSI pattern, yeah, that is significant. So sometimes the Brugada pattern can be seen in patients when they are unwell with the illness, with the non-specific viral illness or any other illness, and they tend to revert sometimes to normal pattern. So if you can see it, it's very diagnostic. Sometimes it can clinch a diagnosis of what was thought to be a pacemaker syncope before in younger patients. You can clinch diagnosis here, and that will lead on to. And she taught us 3 times, but now they merge type 2 and 3 to be just 2 types now. So the coding pattern and the saddleback pattern in the V2, V1, you can see the saddleback pattern here. So and the other is a classical the coding pattern, RSR pattern in V1, V2, and both these things are very typical of or the diagnostic of Brugada and what they need to happen. What needs to happen if they find a Brugada pattern in ECG? They need to have implantable ICD. Yeah, ICD. Yeah, so ICD is the is a treatment, and because they have nonsense in VT just like that, then if they're lucky, they live. They don't think they die. ICD is life-saving. People who have ICD and people who have pharmacotherapy alone was not successful in preventing deaths. There was at least still about 20% of deaths happening. Because ICD is 0 mortality, 0%. Yeah. So arrhythmia, is there any particular rate which can cause the syncope? There's no particular rate. It can be low, it can be high. There's no particular rate which can say we can say is due to that. And it also depends on what is the underlying status of the circulation. They got atherosclerotic arteries, or how their running system is it okay, or is there any underlying problem there, or is there anything else which can lead down to properly functioning autonomic nervous system? And is any underlying structural heart disease as well? any metabolic abnormalities, any alcohol imbalances, any hypokalemia, hyperkalemia, which all can contribute. And if there's up to the normal heart, and then if anything, any problems with the like Brugada longevity, or and there is not much of prodromal symptoms. Yeah, we talked about this earlier on. Medications, yeah. Medications, the whole list of medications, and you have to have some, look at sometimes they will not come with the proper medication list. So it takes some time to look at some care records or GP records or whatever records where you can find out or will come with their list of medications just to see what they are on, and they see whether whether they really need these medications. And that's sometimes they need to do, because in these situations where we are acting as also GPs for these days, in this when they can't access the GPs. So I think it's important that we evaluate these medications, interpret the medications what they're on, and see whether they really need them, I tend not to stop medications or change dosage of medication and stuff just because it becomes a problem for the patients, and it's left to the GP and to make alterations unless it is causing a significant symptoms in when they are when blood pressure is dropping significantly, and it's important that they have to reduce those that kind of stuff. I advise and whatever changes I make sure it goes on to the GP records. So that means there is some clarity in the communication, what we tell the patient as well as what tell the GP. Okay? So interrogate the medications: antihypertensives, beta blockers, diuretics, antiarrhythmics, antipsychotics, antidepressants, alcohol, phenothiazine. So the patients can be on these medications for some time where there's any change in these medications. So there's an increase in dose or decrease in dose, or is anything being added on to them, all these things will have to be interrogated and as to the clues of the reason behind the present syncope episode. Yes, syncope delta can be because of the physiology there. They come structural problems. This circulation is not in this similar state as the vessels become atherosclerotic. There are structural problems in terms of fixed valvular lesions, and there is other comorbidities and multiple medications. They all can contribute. Yeah, last but not least, you should not forget the important life-threatening ABCD problems. Yeah, so you need to evaluate those things and look for any underlying cause of the syncope episode. And these are all quite self-explanatory. We should not be missing those kind of air dissection, tamponade, medicines, SVC obstruction. The presenting a syncope can most often be because of the massive PE. Yeah, so it's unlikely you will miss them. History. So this is in general about the various causes behind the. So far we talked about the pathophysiology, how does somebody encounter syncope, and what are the types of syncope, and in syncope itself, what are how you can classify, and what are the types which what are the conditions present as T-lock, syncope. Along with that, it can be epilepsy and psychogenic. So, and in syncope, how we classify them, and what's pathophysiology so far, and what are the conditions which can present as syncope. But now we're going to touch upon how we're going to evaluate and how we're going to assess them, and which will aid us in the initiate the investigations and giving them some advice on management. So if somebody want to start off with that, I'm sure you all would have dealt with this kind of patients. How are you going to start the history? So we can have a bit of discussion here. Anyone can start. It's a long silence here. Go on, guys.
Couldn't hear you properly. Can you tell me a bit
So
more?
how do you start history? What are the things you assess in the history?
First, you ask about what happened soon before the episode, and collateral history, if possible, what happened during the episode and what happened after the episode.
Yeah.
I think it will be really helpful when
Yeah.
you're taking good history.
Yeah, so history is vital because most of the time the diagnosis is based on history because some of the examination is normal unless you find diagnosis of orthostatic hypotension and stuff. So the history is vital. So, and sometimes history is not very easy to get it by, isn't it? Sometimes there is no bystanders. Sometimes the people who see them, they want to say what they think is happening rather than what's actually happening. But these days, with the advent of these smartphones, they can see whether they got a video recording of what's actually happened, how the color changed and stuff. So what before, after, and yeah, before, during, and after. That will give us an idea. Yeah, before, during, and after. And the 3P. So if they had any provocation, an infrodrome, and what was the posture? Were they standing, sitting, lying? That is very important. So they cover the 3Ps. And if they had any kind of aura, if they have any kind of undefamiliarity of something is going to happen, they can any abdominal sensation or abdominal sounds or anything like that. And any predisposing factors, and what happened during the activity. Did they change any color? Did they go pale? Did they upright when it happened and then they fell down, or with this additional movements of jerky movements which happen before the fall, after the fall, or is any injuries or is there any incontinence? And how long after the event did they recover? What was their responsiveness? Were they unconscious for a long time, and how long it took them to recover? Is it immediate or is it sometime? And anything less than in the basic syncope, we expect the recovery to be quick, less than 1 minute. There's anything around 5 minutes expecting in patients who has epileptic seizures can happen 5 minutes. Anything which lasts 30 minutes and that kind of thing, more than 10 minutes, 15 minutes, it is most often or most likely to be to psychogenic, on any amnesia, headache, any muscle pains, all those kind of things, just to document. Witness history is very wide. If it is available, it is very good. But if it is not there, it is you're not getting into the details of what happened. But at least we can have a history of any prodromal symptoms. How well was the patient? Were the patients completely well? Suddenly this happened, or they were worried about something, worried about some fearing about something about about the work, or anxious about something, interviews, or anything, which can contribute to that. And most of the time, in these age groups, the syncopal episodes, vasovagal syncope especially, happen as a bimodal pattern. It can happen in the adolescent period, or the second phase is in the 50s to 60s. And often the patients who had an episode, most of the patients who had a vasovagal episode tend to have an episode earlier on. So to document whether they had any previous similar episodes, that would help. And any medications and any suggestion of arrhythmia or ischemic symptoms, chest pain, breathless, and postural symptoms, whether they are upright, standing, sitting, it is very vital, because if they have symptoms when they're sitting and lying, then we need to consider, is there anything else which is causing the syncope rather than attributing to vasovagal, and any history of sudden death less than 60 years, which we need to think about any arrhythmia or structural cause before we put it down. Evaluate, so fully cardiovascular, looking for the valvular lesions, looking for the volume status, looking for their, including these, called ECG later on, and blood pressure, both arms, lying, standing, and full nephrologic examination. And let's obviously do the following thing. This is just it's not particularly relevant in our department, in our ED disposition, but it's relevant for when we dispose a patient of what to say and what will potentially can happen, and it is to have some idea about what can happen for them. If there's a structural disease, abdominal ECG, yes, then they get admitted for further investigations, be it is it the left heart catheter? These days they do left heart catheter, and then look for any potential arrhythmia as a reason, and then take the cardiologist. If it is not, then depending on age, if they are less than 60 or more than 60, could be possibly characterized hypersensitivity, or less than 60 dB. Is it frequent or is it infrequent? In patients who have one single episode, not and it is if they are provoked symptoms, then they don't need further investigations. Only patients who are recurrent, younger ages, they are recurrent and unprovoked, and leads to some injuries, and they need further investigations. And often it is left to the GP to do this investigations. So this often characterized as massage is not particularly advocated to do it in ED, but when you do that, that's it's not particularly not recommended to do it to diagnose it, but because of the risk of TIA and things which we say before, but often that is unproven. If they have history of, when they turn their head to side, or and then this is a possibility, then it can be done. So again, it's contraindicated TIA or stroke in 3 months or any carotid injury. So it's of you need to look for this kind of stuff before you think about these things. But what they find, what is the diagnostic thing, is when their heart rate drops or their blood pressure drops to less than 50, then you diagnose carotid sinus hypersensitivity. So the table reproduces the postural stress. So it reproduces neural mediated syncope. So it is again recurrent syncope. Again, patients who are having recurrent syncope causing injuries, especially if they're doing some high risk occupation, operating heavy machinery and stuff. So you need to kind of and it makes we are suggesting lifestyle changes for them, because they involve in operating heavy machinery, then they have to change occupations and stuff, which is quite a massive thing. So in those patients, we have to refer for further investigations, especially tilt tests. And if the endpoint is if they have the symptoms along with that bradycardia or hypotension, then it is the endpoint. And again, you need to find out, especially in people who are having the postural orthostatic hypotension tachycardia syndrome, postural orthostatic tachycardia syndrome, the POTS. They are certain of individuals, especially the women, they tend to present with those kind of symptoms, and sometimes it can be quite scary that they become asystolic for a longer period, requiring sometimes CPR, but unfortunately, sometimes the treatment for that is lifestyle changes and lifestyle modification. That is what they advise. ECG monitoring. So when will you suggest somebody for ECG monitoring, like 24 or 48 hour or event recorder, which is like 7 days when they monitor the ECG. So if the syncope occurs during exertion or sometimes in their supine, and any palpitations, associated palpitations or the feeling of palpitations when they had a syncope episode, or a family history of sudden death, nonsense NVT, and bifascicular block, prolonged short QT, fixed QRS, and Regarda pattern. So any of these abnormalities, then you suggest them for depending on their symptoms and how they present. It depends. It determines whether they have inpatient monitoring or outpatient monitoring. Yeah, so this is about the type of monitoring they require. Holter monitoring is it's a very low yield, because sometimes the symptoms are infrequent, like they happen once a week or once, unless they happen a few times a day, then the chances of them picking up abnormal rhythm or arrhythmia is very less. So most of the time they require an event recorder to pick up the arrhythmia. Yeah. So in patients more than 40 years of recurrent syncope, no structural heart disease, normally is arrhythmia, no cause of syncope found in 50% of patients. Often it is the very irregular episodes. But it's important that to, most of the times in patients who have recurrent episodes, we need to investigate them. But often it is no cause found for the syncope. Risk stratification scores, lots of scores are there, but none of them found to have any clinically valid, any clinical use. So this San Francisco score, sorry, is it? Sorry. Martin score or SIL score, exit score, they have no clinical role. So management, it depends on what we think about in what we kind of had in our initial evaluation, and what we are diagnosing here. So is it secondary to a cause, or is it no cause found? So in general questions, if they have any the 3 B's, they have the prodromal symptoms, or they had any provoking factors, and then you can identify. If they can identify those kind of symptoms, what invokes them, then they can avoid those and the triggers, and take some measures to terminate them. So, for instance, if they are in the right, then they can lie down and see what happens, and they can take some physical counterpressures, which can increase their peripheral, reduce peripheral pooling, increase their venous return. Drug therapy is not much of evidence there, but patients who are known to have this orthostatic hypotension due to persistent orthostatic hypotension, then there is some evidence that they can start on the medullary corticoid stuff. Pacemaker only for patients who are proven to have arrhythmias on lip recorders, or patients who are known to have any kind of arrhythmias or asystole. They can have the or ICD. So what I mean is pacemaker ICD for patients who are asystole or non-sustainability or VF. In general, patients who are more than 50 who are found to have no particular reason behind it, and often the epilepsy is kind of a compounding factor in the etiology or in the diagnosis. The cardiac cause is often the reason behind the syncope rather than an epilepsy, if we kind of have a state like that. Because if the cardiac cause is the reason behind the syncope, then it poses a serious risk for them, because it can recur one. Secondly, it can lead on to even worse outcome the next time it happens. For instance, I saw a 60-year-old man who is fit and well, that he's got no underlying problems at all, not any medications, and he was found to have a feeding episode, or found to have feeding episode. No particular history. It happened at work, and he used to work in an office episode, not in any kind of very heavy history, not involving any heavy work or lifting, anything like that. So the eyewitness account was very patchy, but he was seen in ED, and then history of diagnosis of first seizure was made, and was discharged with first fit episode, first fit advice and stuff. And the next time the seizure activity happened, the patient was sleeping, and wife was sleeping next to him, and was found to have kind of a snoring noise, and wife woke up and found him to have a little seizure activity. And next thing she noticed was him to have stopped breathing, and then she had to perform CPR. And it turned out to have out of hospital cardiac arrest, and he had CPR and he had further CPR, then shock, and then once the paramedics they shocked him, and he had a spontaneous circulation and came to ED, and in ED everything was fine. I think it's abnormal. ECG was normal, because his disease was 3 or after post cardiac arrest, then he had to be intubated, tubed, and everything. And discussed Sheffield, nothing particular to correct. So they said, no, not for us to do the angio now. So do a CT and see what happens. CT was normal. So while waiting, after I have CT, while waiting to go to the ICU for further angio and things like that, his ECG changed and he found to have an ST elevation. And so lo and behold, he was, and then he had a non-sustained VT. Then so we captured that while he was on the monitoring, and he was related to Sheffield for inpatient angio, and stenting and stuff. So when you kind of diagnose the first onset seizure in more than 50-60-year-old people, they can have, but it's unusual, and also they maybe have some structural problems before they start to have, like they have the previous TIA, strokes, or previous injuries, something which can happen, which contribute to that, some structural problems, and often CT is important to rule out those kind of things. And as an ED, later then you had MRI, EEG, and stuff. But what I'm trying to say here is to have a little bit more probing in terms of the history, and see what is what, and that will help us to classify that it could be an epilepsy, or it could be just a syncope episode, or it could be some underlying cardiac cause for that. Often, if it is not apparent, then it is safer to label it as T-lock rather than as a syncope episode. And so, what it means for the patients in terms of driving occupation. So even that is a kind of a single episode, and there is some provocating factors are there, and there's some prodromal symptoms are there, and the patient is upright and can know what happens. And if it is no, then there is no need for any restriction for driving. If there is unexplained syncope and there is no cause found, there is no prodromal symptoms, and it's unprovoked, then they have to stop driving 4 weeks and await the investigations. And if it is a high risk features are present, or if it's recurrent, then it's 6 month ban. For seizure, automatically it's 1 year they can't drive, and it is important. It is to inform the patient, and patient has to inform the DVLA, and it is the patient's responsibility to inform the DVLA, and it has to be documented in the notes, because it is a medical legal aspect of care. Unless the patient is being referred to some of the specialties, and they have to do that. But it is also imperative on us to do the discussion, have the discussion, and document the discussion in the notes. Okay, 80-year-old man presents with a history of collapse. He had a normal examination. Blood pressure was 60, sorry, heart rate is 60, blood pressure was 140, something like that, and the examination was normal. And ECG was done, and it shows this.
Pacemaker.
Yeah, because it shows
Complete heart block.
complete heart block. Yeah, complete heart block. Yeah, is it okay? Yeah. So he needs his pacemaker. So he needs to stay ECG monitoring. Young lady, syncope episode in a warm train, used to faint as a child. So potentially basically unless she is not having any pregnancy, or you want to rule out pregnancy or ruptured ectopic, or that kind of stuff. Yes, they can have most of the patients who have a syncope episode tend to have, as I said, another episode. Mostly they have a previous episode like that. But it's also important that we also rule out other causes. like in this lady, to have make sure that she's not pregnant and then she's not having any undergoes bleeding or miscarriage or ectopic. Which of blood pressure results would be indicative of orthostatic hypotension? Standing, lying,
C.
140, B,
C.
C, yeah, C, possibly,
C.
C, 20 something like that. Collapse observations, stable, how will you proceed? No chest pain, no shortness of most work, 20-30 minutes stopping, doing shopping, suddenly fell down. Can't remember tripping or feeling dizzy. Normal examination, normal ECG, normal bloods. What will you do? Which is sometimes happens, isn't it? You
And
find this.
CT head?
Sorry?
CT head?
Yes.
Monitoring.
CT head, yeah, CT head, why? Yeah, presence
And
collapse.
BP referral to arrange this cardiac monitoring, 24-hour tape.
Heart monitoring.
Could just be a vasovagal syncope. As
yeah,
well.
just like vasovagal.
Yeah.
Possibly.
Oh,
Possibly,
But
but
he's
lying and standing blood pressure.
80-year-old patient, high risk of cardiovascular event.
absolutely, yeah.
I mean,
So in this,
yeah, Rangani, first you take history, is it? So do history examination. CT scan is good. CT scan is a lifesaver.
yeah. So they can have either, but like obviously, you're taking a good history to see what happens. But sometimes the 80-year-old, you can't. However, you prompting, you're probing, the history is hard to come by because of their cognitive impairment, or because they are not bothered. No, what is there? No, 80-year-old, I'm just living, I'm just happy. Don't probe me. Don't. I don't know. Sometimes they are tired. Or as simple as that. The history is hard to come by. So, if the history is some 80-year-old sharp lady, sometimes they can have a very good particulars. I was complete. I know what I was doing. I was sewing there, I was making a cup of coffee, whatever. They can go into complete details of what exactly happened. But sometimes it's very difficult. Yes, if you can get the history, you're lucky, and you can do what you have to do. But if you know, then what I was trying to say is the structural cause is very highly likely. Yeah, she may have a non-sustained VT or VF, and that's very highly likely, unless she has any underlying, she might have a atherosclerotic arteries, maybe in coronaries, maybe cerebral vasculature, but structural regions are high. And how far you can go and investigate, how far you can go in terms of treating those patients, it depends on how the patient wants, what patient wants. So all these things which are beyond our what is it, purview and what we can do, but it requires for us to think on those lines and to refer and for further management and stuff. Yeah. So history is vital. Risk stratification based on clinical evaluation. So what do you see and what is the patient's functional status? What is the patient's occupation, and how it happened? Is it involved? Did this episode lead on the patient having secondary problems like injuries they sustained, and it happened while driving? That led on to have RTC, and that's very important because sometimes patients, young patients who have non-sustained VT and with the underlying regarder can have a serious RTC. So what is the stratification? Is a low, medium, high? It can be recurrent, it can be single episode. That is very important to do. That is all we are doing in our evaluation. That's what normally we do in our ED, isn't it? Anybody comes in, is it likely to go home? Is it going to be done? Or so by doing that, we're kind of stratifying the risk and what is their prognostication we are doing. And we're identifying serious illnesses. And it could be just syncope with no underlying cause, or it could be some syncope with some underlying cause, and anything else which is serious, which need to be addressed right now. And if not, nothing is found, then how are we going to dispose the patient, or arranging them to follow up and advice, as we normally do. Great. Any questions? I hope it must be a
No,
recap of what normally you do. Sorry, Mr. Nijwa. Go on, Mr. Nijwa.
Mr. J, you're muted. Mr. Junja, you're muted.
Yeah, I think it's a very complex subject which Dr. Babu have touched upon, and we could see from his presentation, it's a really wide and complex subject. I think the essential message is at the end that don't miss the serious stuff. But I think to me, medicine is simple. What we need to survive: water, sugar, and air. Now, hence you can build up the picture from there. If we think a system which have got a couple of reservoirs connected with the tubes and the wires, so then the thing gets a bit more simple. I think in that subject, if we think like a little bit neurophysiology, because we need that to understand, and then metabolism, cerebral perfusion, and intracranial pressure. I think they are quite related with each other. The history, very important, as Dr. Babu is saying, that taking proper history will identify quite a bit of situations where you can exercise the option of doing nothing when you treat it. Investigation, as we're talking in the previous talk, that there are general investigation which we need to do on all these sort of patients. But when the special investigation comes in, like a CT, MRI, these sort of investigation, please ask the question. So, the CT is not the first option. I think, first we do all the other stuff. The treatment point of view, again, we correct hypoxia, hypovolemia, hypoglycemia. We give antidotes, in this situation if it's needed. Antibiotics, antiviral, cyclovir, and anti-epileptic. I think what other treatment we give? There's a general set of treatment. So I think the success to the successful outcome is being simple, being systematic, and thinking of like a basic set of, medical knowledge, and then building upon that knowledge. For instance, if the water is inadequate, then we start thinking, oh, if any tube is broke, if any leak there, or if the water is enough, or the hypovolemia. In the modern set of big terminology is hypovolemia or hypoperfusion. If there's a hypoxia, again, if the air is not there, then we start accessibility. Again, the same sort of line of thinking. So if the air is enough going in the body, if the exchange mechanism is correct, the lungs and, then the hemoglobin. And similarly, substrate like a glucose, so glucose, brain doesn't store any glucose. So it's any metabolic problem, accessibility to the glucose, or, I think if you think in those lines, things start getting simple and easier, and the outcome is always successful. Very good talk, comprehensive coverage. Well done, Babu. Thank you very much.
Thank you, everybody. Thank you, Mr. Ginger.
Dr. Babu, with regard to this driving license things, can you explain a little bit more that what is the type 1 something?
Type 1 is the normal, the car and minivan. Yeah. So what we for us is type 1. Type 2 is the heavy vehicle, heavy goods vehicle license. There are no lorries and trucks and stuff. So
it is always the patient's responsibility to inform, and it's our responsibility to inform the patient to inform, is it?
Yeah. We have to just say, okay, if you had a 100% episode, and if you can have a unprovoked episode, or there's no prodromal symptoms happens, then you have to say, okay, we have a high risk of this happening, and if you are referring for further investigations, then they should not drive within that period unless they have the investigations done, and it is said nothing was found. No, that period, if it is referred to further investigations, then they can't drive 4 weeks time. So they should not drive, and they should inform the DVLA for a certain amount of period of time, and then the further investigations and follow-up has happened, then it's all fine. Then they can restart the driving. There is no ban on that. That's only a temporary thing. Whereas if it is a recurrent episode, and if it is something happens, then only a single episode, if something has happened 6 months, they can't drive.
I think, Bob, this is a bit of a tricky situation here, because
it is.
Because if our work and only I am the breadwinner, that's a very problematic situation. And I think because they have withdrawn the second note from the emergency medicine now, because I remember when we have different books of the second note, we could, retrospectively sign as well if we, all the books are available. Then the review in, I think in 2000 something. Now, I think what I would suggest is we say, okay, so 1 week you can self-certificate, but please ask the GP, because the GP knows more about them, about their, social circumstances and work and everything. And if the GP will give a sick note, then definitely GP will also be writing to the, Social Security and this sort of stuff, because, but some people are covered by the work as an NHS, but some people don't. For example, 0-hour contract, this sort of stuff. They have to go back to the Social Security to get some money to bring food on the table. I think this is a very tricky situation. I absolutely agree with Rangani. Difficult situation, but I will write to GP, that's what happened. And I advise this patient that he should not self-certificate for 1 week. And could you please see him, or the patient is coming to see you regarding all this stuff. Then the GP will pop in, and then he will appropriately, have a conversation with the patient and take from there.
Okay.
Yeah, we can. That is another way of you can deal with that actually. So, but it is imperative for the patients, yes, not for us to tell the DVLA or anything. It is.
Yeah, you're absolutely right.
Yeah, it is their responsibility. Yeah. And I can signpost to this if you think of neurological disorders and assessment DVLA. It's a whole comprehensive list of things, what they can do, what they can't do, and how they are very detailed in that, and say how this happened. Is it a prodromal symptoms were there, and was the patient standing, sitting when symptoms happened? So that kind of stuff. So they are very particular in knowing when this happened and what the patient was doing and how it's resolved. Because as we discussed, it poses a serious question to the patient's lifestyle in terms of their job, in terms of their livelihood and everything. So we have to, again, for those reasons as well, for the advice regarding driving as well, we need to have the history distilled, clear cut to see what happened, how it happened, and these. In fact, they mentioned these 3 Ps in their DVLA guidelines. Okay, so everything they want to know to accurately advise the patient. So that's also very important in in advising as well. So the history is again very important as well. The final aspect. Great. Any further questions, Tom?
I think in epilepsy, when we have a first fit clinic referral, so it's already written on the advice, so we give the advice to the patient. But I think it's important in epilepsy first fit clinic referral, because I'm just like a sideline, because sometimes they write back to me and they say that we didn't receive an ECG, stuff like that. There was a problem with the scanning that we have sorted out now. Yeah, please make sure that the ECG is scanned to the first fit clinic, as Babu is saying, and we've seen through all of his talk that the ECG and the cardiac structure abnormality, these are problem, is make a big chunk of this transient loss of consciousness and the seizures. Yeah, please do remember, make sure that the ECG has been scanned to the neurology clinic in the first fit sort of situation.
Absolutely. Yeah. Excellent. So if there's no questions, then shall we stop? Is there anything else happening, Boone, afterwards, or is that it?
No, that's the end of this morning sessions. Thank you very much, Dr. Babu,
All right. Thank you, guys.
for
Thanks
your
for
comprehensive talk today.
Thanks for this opportunity. I think it's good actually. It's helped me to kind of revise, keep my things going on.
Yeah, I mean these are recorded so that people who who can't make it to today for whatever reason can always access this talk at any time when they're free.
Excellent. Good initiative. Yeah. So I will join in as much as possible and see how my rota allows and stuff. As far as if I'm free on a Thursday morning, then I can do more presentations and I'll keep in touch with you. Boom. Yeah.
No, it's a very good resource.
Yeah.
I think we are thankful to all the contributor, especially the educator who are managing the education, like Dr. Boone and previously Dr. Zia and everything. And I think the individual contribution, I mean, it was very impressive contribution from Dr. Bhusal from Nepal.
Okay.
Very excellent. I think we really like. Flow was good. I think the other thing is we are learning to share teaching internationally now. I think the more we do, the more we will know what the difficulties are and how can we overcome these difficulties. Because our ultimate goal is, quite frankly, going global. Teaching people in different countries, staying there, contributing, listening, discussion. Medicine is a global thing. It's international. It's nobody's monopoly.
Yeah, I mean,
it belongs to every one of us.
I think in about 2 years' time, we will have a good library of different topics that's already in recording that people can access.
Excellent.
We're gonna have, because we cover the curriculum, we cover the new 2020 curriculum. We try not to repeat anything. So in 2 years' time, we will have a nice library of different presentations by different presenters, which then becomes a resource for everyone. I think is useful.
Definitely.
It is. Excellent.
Okay. Thank you very much. Oh, let me just stop recording now.